Hi, this is E. David Crawford, Editor-in-Chief of Grand Rounds in Urology. Joining me to update a presentation that he made several months ago is Dr. Alan Bryce, who's Associate Professor of Medicine, Mayo Clinic in Arizona. Alan, please give us this update, and thanks for your time.
Thanks for having me, David. Happy to be back. Happy to be talking about what I think is really a very important topic. That is changing the way prostate cancer is being practiced. So, without further ado, the background on this, of course, is that genetic testing is really now part of the best practice for the management of prostate cancer. The era of using genetic testing in the management of prostate cancer is now here. So, it's certainly something we all need to be facile with, comfortable with. But it remains a confusing topic, and so I appreciate this opportunity to try to perhaps clarify some of the details around the how and why of genetic testing. The first thing we always need to specify is what kind of testing are we talking about. And the first distinction is to differentiate between germline testing, which is testing the inherited genetics of the patient, so the patient's baseline genetics that he received from his parents and that he then might pass on to his children and shares with his siblings, versus somatic genetics, which is testing the genetics of the tumor. So cancer, of course, being a disease where cells have mutated to become cancerous cells, there are always going to be some genetic signatures in the cancer cell that are different from the healthy cells in the patient. And then within somatic testing, we need to talk about the different ways of testing. And the gold standard remains a biopsy of the tumor tissue itself, which is tested for various kinds of genetic aberrations. But there's also cell-free DNA, which is a blood-based assay testing circulating tumor DNA in the blood. And this is very timely in prostate cancer because, of course, there's plenty of patients where we can't get a biopsy. And when we can't get a biopsy, cell-free DNA is a good alternative way to measure some of the most important mutations in prostate cancer. So why test? First and foremost, the fact of the matter is at this point it is recommended, both by the SGO and by the NCCN. It is now a level 1 recommendation that all men with high risk, very high risk, or metastatic prostate cancer should have germline testing. And it's also recommended for men with very low risk, or intermediate risk disease if there is a family history or intraductal histology. And it's relevant to the patient both for his treatment options in terms of systemic therapy, but also relevant to the patient's family. Because, of course, anything that the patient has in his germline, there's a 50-50 chance that any first-degree relative will also have the same mutation. So that is siblings, children, parents. And then why for somatic testing? It's really because it can guide systemic therapy, and some of the results can give the patient treatment options, non-chemotherapeutic treatment options that he otherwise wouldn't have. So in terms of germline testing, here at Mayo Clinic, we've done a study of several hundred men with prostate cancer, all stages from early to metastatic, and approximately 15% of them are going to carry a known hereditary cancer risk gene. The most common are going to be the DNA repair genes, so BRCA2, ATM, and BRCA1. These are going to occur in almost 10% of patients. And these genes are not only associated with prostate cancer, but they're also associated with breast cancer, ovarian cancer, pancreas cancer, and others. So here again, when we say it's important to the patient's family, it's not only the men in the family, it's also the women. The second most common category of mutations are in what we call mismatch repair genes, and there's a few of them listed there. And these are the genes that are most commonly associated with Lynch syndrome. And these are thought to be associated most with colon cancer, with endometrial cancer. And then for the urology community, of course, this is associated with upper tract urothelial cancer. But these also occur in prostate cancer. So here again, if you find this in the germline, this can be relevant both for your patient in terms of what other cancers does he have to be screened for, but also relevant for the patient's family. So remember, if your patient is a carrier, you need to recommend testing for his children because you can save a life through early diagnosis, right? I mean, and we all know this. I'm a medical oncologist, of course, but I would much rather the surgeons cure the disease early through early diagnosis rather than the patient, ever reaching me. All right, so somatic testing. What about testing of the tumor? The key here is that we now have approved therapies for some of these somatic mutations, and these are therapies that the patient can't get unless you first show that the mutation exists. So for patients with BRCA mutations, that is BRCA1 and 2, 1 or 2, PARP inhibitors are now approved. So just in the last month, rucaparib and then olaparib were both FDA approved for treatment of metastatic prostate cancer with BRCA mutations. In this case, the mutations can be germline or somatic. And the FDA approval does extend to some of these less common DNA repair defects that we're not covering here in the interest of time. But what's important is that these drugs, rucaparib and olaparib, are oral therapies that are quite well tolerated and have very high response rates. I mean, PSA response rates over 50% and potential for durable response of greater than 12 months. I have patients in my practice who have benefited for more than 2 years on these oral therapies. But it's not only PARP inhibitors. There's also the potential in genetic testing to find MSI high, so that's microsatellite instability, as a genomic signature on tumor biopsies, or something called tumor mutational burden. And if the patient has MSI high or high tumor mutational burden, then the use of immunotherapy is actually FDA approved. So you probably know that immunotherapy doesn't work in most prostate cancer patients, but it works in patients that have these genetic signatures. And the FDA has approved pembrolizumab for use in tumors that are MSI high or high tumor mutational burden. Now, this is less than 5% of prostate cancers, but when it's present, the responses to immunotherapy can actually be quite dramatic. And of course, the side effects of immunotherapy are generally much less than chemo. So this is an attractive treatment option for those patients in whom the genetic signature exists. So, in summary, what do I recommend? Somatic testing. At this point, we should test every patient with metastatic prostate cancer. And when testing for tumor mutations, the key is you want to know what the tumor looks like today, not what it looked like 10 years ago when the patient had their prostate biopsy. So it's fundamentally important to use fresh tissue. Preferentially, I like to use a fresh biopsy. But if a biopsy is not possible, then by all means, we can do cell-free DNA. And cell-free DNA is just a blood test, right? And there's multiple commercial assays that one could use to do this. Cell-free DNA it works. It has a high correlation to tumor biopsies, to fresh biopsies. So when you get a positive result, you can rely on it. But the last point I'd make is you have to retest patients. When managing metastatic prostate cancer, it's important to remember that there is Darwinian evolution going on while we treat patients, right? The chemotherapy or the oral hormonal therapy or whatever therapy we give to patients is actually the selective pressure that's going to cause natural selection on the tumor. So each therapy is going to cause the tumor to evolve. And so in my practice, I retest patients at every progression so that every step along the way we can see how the tumor mutated, what it looks like today, and hopefully then be able to offer a more attractive treatment option to the patient. So that's all I have for our 2020 update. Certainly happy to take questions. You can email me through that email address that was on the first slide. Thanks very much.
Thanks, Alan. That was a very nice update. A couple of quick questions. You talk about the guidelines and with family history of prostate cancer may be a reason. Can you define what a family history is? I mean, we see people with that have one relative, three relatives, different sides of the family, and so forth.
Yeah, so this is a really important point, that family history is a traditional way we all learned how to talk about genetics, right? This is what we learned in med school, and up until the modern era, all of the guidelines have been based on this idea of family history. So you're talking about first-degree relatives, you know, more than two people who have, you know, this specific cancer before a certain age, etc. One of the things I would emphasize, though, is that all those family history studies, you know, were based upon very large families with extensive genealogies, where the epidemiologists could really do, you know, great analysis. But nowadays, you know, the average family has 2 children, right? And there's plenty of people who either are orphans or they have one sibling, or, you know, the family members, you know, died young through other causes. So I think one of the most important messages is don't rely solely on a family history. Okay? Right. Our study of prostate cancer patients, where we found a 15% positivity rate, we didn't take a family history at all. We just tested everybody, you know, these several hundred consecutive patients. And even if you don't take a family history, you're going to find a cancer predisposition gene 15% of the time.
Interesting.
So that's really the key. In my practice, every patient, first visit, we talk about getting their germline done, and almost everybody is tested.
So if you do look at family history, it's just not one person. You're looking probably for multiple family members. Is that right?
Yep. And you know, keep in mind, you're not just asking about prostate cancer. You're asking about any cancer, not just in men, but in men and women.
Ovarian and melanomas and other things like that. Let me ask you one more. Well, I'll make a comment that I always learn a lot when I listen to you, but the cancer being sort of a moving target and retesting before each new systemic therapy, I don't think most people are cognizant of that. And that was an important take-home message here.
Yeah.
So
yeah, it really is key, right? Because you know, we're keeping patients alive for, you know, 5+ years, and they're going through, you know, 4, 5, 6 lines of therapy, and without question, you know, the cancer at the end is different than it was at the beginning. And I think, of course, we all know this clinically, right? We've seen cancers that just get more and more aggressive as time goes on, and that clinical course is reflected in the genomic signature, right?
We all know that.
Genomics is just confirming what we already know as clinicians.
Yep. I mean, we know that cancer is a collection of genetic changes, and the longer it's around, the more genetic heterogeneity that exists, and the less responsive it is to therapy. And this is, you know, it's important to look at that now. Thanks for sharing it. I guess I have another quick question, and I think our audience might like to know, what about reimbursement for multiple tests like this? If you're doing it several times, you run into any roadblocks or denials?
What I found is, you know, payers have accepted this now. This is very much part of the norm. And of course, most of these tests actually cost, you know, no more than a CT scan, or often less than a CT scan. So in terms of the, you know, cumulative cost of care, this is not a major component. You know, a month of all these new oral drugs actually costs more than these tests.
Great.